is something called hand surgery, right? So hand surgery is right now, it's a super specialty department. It's a super specialty posting, and I think some of you in the next 10 years may go in for hand surgery. It is something you do after orthopedics, after plastic surgery you can do it. It is something to deal with the hand, and from the fingertip to the distal radius, this is the hand, and it is a very important structure, as all of you know. So your dominant hand, if it's right or if it's left, if it gets injured, so that is a very difficult thing to manage, and it needs to be managed well so that you can give the patient a good quality of life, right? So we come to something called hand fractures, which will deal with the fractures of the hand. From here, not many short notes are there. I'll just come to the short notes a little later. And there are also some conditions of the hand that you need to know about. Those are the short notes that I'll tell you as we go along, okay? So the basic anatomy is, you all know, from the distal radius, there are the carpal bones, the metacarpals, the phalanges, right? And there are the lumbricals and the interossei. These are the muscles holding it all together in the hand, right? The blood supply, it has two arches, the dorsal arch and the ventral arch. And if any one is damaged, the other takes over. And the nerves of the hand, we'll come to it later. There are some conditions involving the nerves of the hand, which you need to know about because the short notes come, right? Now, hand fractures in general, the management principles are, the mechanism of injury should be calculated before. The main type of injury to the hand comes from blunt force trauma. If someone is punching someone, this causes fractures of the hand. It comes from crush injury, if the hand is put under something heavy, or a car runs over the hand, that is called a crush injury. Or it may become a mechanical injury where during the course of work, someone puts their hand inside a crusher where the hand or the finger is torn off, right? So the mechanism of injury should be assessed. Fracture reduction and reduction maneuver should not cause additional trauma and should be gentle. The hand fractures, you do not use blunt force, right? You use gentle force, and a complete neurovascular examination should be done, determining whether the blood supply and the nerve supply of the hand is intact or not, right? So next we come to the orthopedic point of view. Radiographs, at least two projections centered at the level of interest. Oblique views, if you're getting an X-ray of a hand done, right, you always get an AP and an oblique view. You do not get a lateral view done, because in the lateral view all the bones are overlapping and you will not be able to see an individual fracture there. So it's always AP and oblique. There are some named fractures here in the hand. One is of the thumb, right? First one is Bennett fracture, right? Bennett fracture is a named injury. This you should write down. Bennett fracture, this is important. It was coined by Dr. Bennett. He was Irish in 1882. It's an intra-articular fracture. What's an intra-articular fracture, do you know? An intra-articular fracture is one which goes through the joint. Any joint involved in a fracture, that fracture is known as an intra-articular fracture. So this is an intra-articular fracture. The shaft is dislocated laterally. I'll show you the picture in a few minutes. And the medial fragment remains in place due to the volar oblique ligament. And the abductor pollicis displaces the shaft laterally. Management is operative. It is done by K wires, right? K wires, you fix it with the K wire. I'll show you. This is the fracture, right? This is the fracture, right? It occurs here in the first CMC joint. This is the fracture, and this displaces laterally due to the pull of the abductor. This is the abductor. It pulls this fragment away, and this is held in place. So this, and it is through the joint. This is the joint, and the fracture is through the joint. So this is a Bennett fracture. It's an important fracture, named fracture, and it can come as a short note, right? This is the radiographic feature of a Bennett fracture. It's through the joint, you can see. This is the joint, and the fracture has gone through the joint, right? This is the technique of reducing the fracture and fixing it. This is a K-wire and it is being used to fix the fracture, right? The Bennett fracture. This is the final picture after reduction, X-ray picture. Post-operative care, mainly you have to immobilize the joint. So you used a cast for 4 weeks, and if screw fixation is used, that is inside, so you can allow movement of the hand. If K-wire is used, you need to keep it in a cast, at least a slab or a splint, so that it does not move. And you remove the K-wire at 3 weeks, and then you allow movement of the hand. So that's a Bennett fracture. I'll show you the picture again. This is the Bennett fracture, right? It's an important fracture. It's basically due to, it's an intra-articular fracture to the base of the first metacarpal, and the shaft is dislocated laterally due to abductor pollicis longus, ABPL, right? You need to remember that. ABPL pulls it laterally. That is the ABPL. In the short note, as soon as you write, it's an intra-articular fracture of the first metacarpal. That gives you 1.1 number. The next thing is the abductor pollicis longus. You write it, get a second number, and you write the management. If you can add a picture of it, that's even better. And that's it, right? Next, we come to something very similar. It is another base of metacarpal, first metacarpal fracture. It's known as a Rolando fracture. So first we had Bennett, now we have Rolando. It is a comminuted first metacarpal base fracture. It presents as a Y or T pattern, and it differs from Bennett because there is no diaphyseal movement of the fragments, right? The management is similar. This is a Rolando fracture. See that in that picture we saw only one fragment here. Now there's another fragment here, right? And it is a Y shaped. Can you see the Y? Y or T, right? That's a Rolando fracture for you. This is a Rolando fracture, see. This is the mechanism of management. This is the fracture. This is basically a Y shaped, and this has been reduced later with K-wires. This is a K-wire and it has been reduced. So it's a very similar fracture to a Bennett, but it has another fragment which is, and it may be T-shaped or Y-shaped. Same, so first metacarpal base has two types of fractures. One is the Bennett fracture that I showed you right now. Only one fragment is there. This is a Rolando fracture where there are two fragments, right? And it's a T or a Y pattern. And that is, this is the X-ray picture, something you'll get. And this is managed by K-wires as well as an external fixator, right? And you can see the K-wires inside. This is a post-operative picture. You can also use clamps to reduce it. You can see the fracture well here. It's a Y-shaped fracture, right? And you reduce it with clamps or through traction, and then you use K-wires or screws or plates. Very small plates are used here. So you may omit that. K-wire treatment is, in any hand fracture, one thing you should remember, if it comes as a short note, or if someone asks you how do you manage it, write one thing, K-wire, that is it. In a hand fracture, any type of fracture, K-wire fixation is done, right? There are also carpometacarpal joint dislocations, rare injuries, right? And mostly dorsal dislocations are reported. The carpometacarpal joint is here. The Rolando and the Bennett fracture involves, both of them are intra-articular fractures, and they involve this joint, carpometacarpal joint. Not much, do not write this down. This is a thumb mobilizer. This is just, I'm going through it. You don't need to remember anything of these. Metacarpophalangeal joint fractures are also there. Remember Bennett and Rolando, right? This is something you need to remember. Rest, these are just for show. I'll just show it to you. This is a dislocation. Can you see the dislocation? This is basically the metacarpophalangeal joint. This is the first metacarpal, and the Rolando and Bennett fractures were here, right? And this is the metacarpophalangeal joint of the thumb. This gets dislocated many a time, and you have to reduce it with either traction or the deformity needs to be corrected, right? Okay. Now this is something that comes as a short note. It's known as gamekeeper's thumb or skier's thumb, right? S-K-I-E-R. Skier's thumb or gamekeeper's thumb, right? I'll just write it down. It's not written here. Skier's thumb or gamekeeper's thumb. This comes as a short note. I'll go into the details. Why is it known as a skier's fracture? Because people who ski in Switzerland, in any icy area, people ski, and if they fall down, they land on their thumb first, and this causes an injury which is known as the skier's thumb. That's why skier. People who ski on icy slopes, they have this injury more commonly. That's why it's known as a skier's thumb. It's also known as a gamekeeper's thumb because people who wicket keep in baseball as well as cricket, they also have this injury because the ball touches this part of the thumb and causes this injury. So this is originally described by Campbell in 1955. This is known as gamekeeper's thumb. And they also occur in basketball players because of the same thing. The ball injures the thumb. Skiing accidents, falls with forceful radial and palmar abduction. So this is also known as skier's thumb. So what is it? It is basically the rupture of the UCL ligament, ulnar collateral ligament. This you need to write down. This comes as a short note. So gamekeeper's thumb or skier's thumb, if it is coming as a short note, what you need to write is, it is the rupture of the UCL ligament, which is the ulnar collateral ligament of the thumb metacarpophalangeal joint, right? The heading here, this is what is you need to write. The thumb metacarpophalangeal joint UCL rupture. This is basically the injury that occurs in gamekeeper's thumb or skier's thumb. We'll come back to it later. Just write down the name of the injury. I'll come back to it. This is the ulnar collateral ligament of that joint. It's a very small ligament and it gets injured very easily. And this causes, the problem that it causes to the patient is that it is, the joint is unstable. So the patient cannot move the thumb easily, and that's why it needs a management. This is the ulnar collateral ligament which is torn, right? No need to remember all this, right? We'll come back to it later. I'll tell you what to write down. Carpo-metacarpal joint dislocations are not that common type of injury. These are the metacarpals, these are the carpals. This is the dislocation, very minor dislocation. You cannot truly appreciate it on this X-ray. Okay, this is a common fracture. Don't need to write it down, right? I'll tell you what to write down. This just listen to it, what it is. This is the base of the fifth metacarpal base fracture. This is the fifth metacarpal. The base of this gets fractured. It is a disabling injury and malunion may require a corrective osteotomy later. So this is the injury. This is the fifth metacarpal. This is the first metacarpal that we were talking about. Second, third, fourth, fifth, right? And this is the dislocation that occurs. We'll just rush through this. No need to remember all this. These are basically shaft fractures, metacarpal shaft fractures, boxer's fracture. This is something, boxer's fracture, basically it is a very common injury and it is a metacarpal neck injury because people who punch someone or punching the wall, it comes to us very frequently and we ask the patient, how did this occur? So he says, in a fit of rage, I punched the wall. So if you punch the wall or you punch a heavy object, it used to occur in boxers first. So this gets fractured. It's a very common injury. We get it in the OPD very frequently. Metacarpal neck fracture involving the little finger. The metacarpal head is freed from any proximal stabilizing influence. So the metacarpal head tilts volarly, right? This is the fracture. Can you appreciate the fracture here? This is a very common injury that comes after a patient has hit the wall or has hit someone, right? And the management is same, KOR, right? This is how you manage that with a cast. No need to remember all this. This is a metacarpal shaft fracture managed with a KOR. And you can also give a plate here. This is the metacarpal shaft fracture here. two metacarpals are fractured. And this has been managed by. So now phalanx fractures, we are going distally. So we talked about metacarpal fractures, first metacarpal base fractures, carpometacarpal dislocations. We talked about boxer's fracture. So boxer's fracture is fifth. And now we come to the phalanx. So the phalanx may get fractured. It's also a very frequent injury. And you need to remember that this may be an injury. It almost always comes as an open injury. This is the type of injury that comes, right? It's an open injury. It may be due to a work force trauma or a blunt force trauma. And this is the extra picture of this patient, right? And you manage it with KOAS. Same thing. Anything of the hand, you need to mention one thing. If the management is asked to you, always remember KOAS. You need to write that down, so that gives you one extra mark for that. No need to remember all this. This is all fractures of the phalanx. You can see this fracture, phalanx, and it is managed by this way, right? So that you can allow movement. This is the distal phalanx fracture, see. And again, it's managed by KOAS. So anything of the hand, always it is managed by KOAS. You need to mention that. Now we come to mallet finger. We'll come back to this later. Write this down. This is also a short note. So we talked about 4 short notes here. One was Bennett's fracture. One was Rolando's fracture. One was skier's thumb or gamekeeper's thumb. And the 4th is mallet finger. So what is a mallet finger? Why is it known as a mallet finger? Because this injury comes commonly with people like carpenters who work with hammers. So they, by mistake, injure their fingers and it causes a deformity like this. And they cannot extend their finger. The finger is always flexed. In this type of a deformity occurs and you cannot extend it. So there is basically distal interphalangeal joint extension lag due to the disruption of the terminal extensor. Basically, this is the extensor tendon. This is the finger. We are flexing it. So this is the flexor tendon is on this side and the extensor tendon is on this side. That's why you can keep it straight. This is the flexor tendon and this is the extensor tendon. If the extensor tendon gets ruptured or there's a fracture there, so you cannot extend this distal part. So it is flexed, permanently flexed. Patient will not be able to extend. So this is basically what you need to remember is the distal interphalangeal joint extension is hampered due to the disruption of the terminal part of the extensor tendon. That is the mallet finger. Don't need to know the types. Basically, treatment is, if it is grade 1, then you go for a splinting. Splinting will do. This is a stack splint or an extensor splint. And if it is, again, there is a KO here. So you need to manage it by KOAS. So this is the fracture. The extensor tendon is ruptured here with the bone piece, right? This bone piece has gone off. And you manage it with KOAS like so, right? You have to open it and then manage it, right? I had already told you the short notes from here. We'll just discuss it in a little bit detail. Skier's thumb, this is a very common question that comes. You can see this is a skiing injury and this is an injury to the metacarpophalangeal joint, ulnar collateral ligament, UCL. Remember the short form, UCL. Easier to remember. The full form is ulnar collateral ligament, right? So the injury to the metacarpophalangeal joint, ulnar collateral ligament of the thumb. So this is the rupture that occurs due to fall on the outstretched hand. The ulnar collateral ligament is ruptured. Do not need to remember the Tinel lesion. It's for postgraduates. There is swelling and tenderness over the ulnar side of the thumb. Ulnar side of the thumb means this side, right? Because in the anatomical position, this is the ulnar side. So this side of the thumb presents with swelling and tenderness. There's a bruise or a discoloration of that part, and there's laxity of the joint, which basically is why the patient comes to you, because he cannot move the finger properly. Stress testing is done. Don't need to know, just write stress test, that's all. X-ray to exclude a fracture. It may occur due to an avulsion fracture. So that is what is occurring here. So you see a fragment here. So that means that ligament has come off with a part of the bone known as an avulsion fracture. Minimally displaced fracture, get an MRI done. Ultrasound may also help you. but an MRI is necessary to assess the ligaments. Investigations, complications may occur: chronic instability, arthritic changes to the joint, or stiffness of the joint. Treatment may be immobilization for a partial tear, which will be evident on an MRI. So then you take a decision as to how do you treat the patient. So if in a partial tear, you can give a thumb spica cast for the patient. If there's a complete tear, you need to repair that. So you need to go in for an open repair of that lesion, right? Delayed diagnosis not to be done. If arthritis is present, arthrodesis don't need to know this. Complete tear is operative, immobilized post-operatively for 6 weeks. Operative repair, you need to open the joint and you need to repair that ligament. Operative repair. You keep it in a cast after the repair for 3 weeks. Immobilize anything in orthopedics after surgery is done. You always need to immobilize unless it's it's an internal fixation device is placed inside. If there's an internal fixation device, then you can allow movement. But generally, if there's a K-wire management or any repair, then you have to immobilize. In an orthopedic patient, you need to immobilize for 2 to 3 weeks. After that, you allow movement of that patient, right? So the next short note, mallet finger, that I had come, but I am going to discuss it in a little more detail. Mallet finger, deformity of the finger caused by damaged extensor tendon distal to the distal interphalangeal joint, DIP, right? Also called baseball finger or hammer finger or drop finger. No need to remember, just know that it is a deformity to the finger caused by a damaged extensor tendon. Disruption may be bony, it may be tendinous. It is common to middle-aged males and older females. Involves long, ring and small fingers of dominant hand. These 3 fingers are the most involved, right? These 3 fingers. So basically the mechanism of injury is the same. A ball strikes it, that is the most common mode of injury. If the cricket ball or a baseball has struck that part forcibly, it causes that injury. Mostly we find this injury in cricket players. They come to us and they say that we cannot extend our finger. So then we ask, how did that occur? And the patient says that I was playing cricket and the ball hit that part. Classification, don't need to know. Signs and symptoms, the fingertip drops like this, right? This is the deformity that occurs. Patient cannot straighten it, but passive movement is normal. If you allow the patient will say that I can extend it with the other hand, but actively he or she cannot do it. So there's lack of active DIP extension, and there's swan neck deformity. This is known as a swan neck deformity, right? It looks like a swan, so it is a swan neck deformity. X-ray diagnosis. Now we come to diagnosis. So first, what is a mallet finger? We knew disruption of the extensor tendon. Second, we came to what are the symptoms. Mechanism of injury. Ball injury is most common. Cricketers come to us with this type of injury. Third is signs and symptoms. The patient has a swan neck deformity and patient cannot extend the finger actively. Now we come to diagnosis. Diagnosis is, first of all, you get an X-ray done. So X-ray of this part, basically it's a lateral view. Lateral view gives you the best picture. It's an avulsion fracture of the distal phalanx may be present. Like so. This will be the picture that you get. And you have to know that this needs to be managed operatively. Treatment non-surgical may be done to keep the fingertip straight until the tendon heals, not commonly done. If you find a patient with this type of a deformity, this type of an X-ray, you have to go in for an operative management. Extension splints may be used, but it takes time, 6 to 8 weeks, and then at night for 4 additional weeks may not be satisfactory for the patient. The patient may not want to keep a splint for 6 to 8 weeks. The patient will want to return to sporting activity or whatever. So this is not much used, non-surgical. But always, whenever you come to treatment, you're writing a short note, always mention non-surgical treatment first. Then you come to operative management. This is the splint, extension splint that you give to the patient. Surgical indications are volar subluxation of the distal phalanx, and if non-surgical treatment was not successful. Also, if there's an articular gap, you go for surgical management. What is surgical management? K-wire fixation. CRPP, what is the full form? Closed reduction and percutaneous pinning. CRPP, right? Closed reduction, you reduce it under X-ray vision, you reduce it and then you put a K-wire through it. Pin fixation. Pin fixation is basically K-wire fixation. You may have to open the joint if it doesn't reduce by close reduction. You need to open the joint. And surgical reconstruction of terminal tendon if there is no bony injury. If there is only a ligamentous lag, then we need to go in for a repair. We need to stitch that ligament up. Also, DIP arthrodesis may be done. Arthrodesis means you fix the joint in one position, but usually not done because that will hamper the movement of the finger. Complications, extensor lag, non-union. The fracture may not unite in any orthopedic short note. If there is a fracture, the first and foremost complication that will come is non-union. Always write that so that you get that extra mark, right? Extensor lag, swan neck deformity, non-union. That's it. Thank you. That was. So now we come to some conditions of the hand. So we've done with our hand fractures mainly. So next thing about hand surgery is something known as carpal tunnel syndrome. It's a very common thing. You will find it in aged patients, in your grandmothers or grandfathers. You can see this. What is a carpal tunnel? You know what a carpus is. Carpus is a word derived from Greek word karpos, which means wrist. So the wrist is surrounded by a band of fibrous tissue that normally functions as a support for the joint. So the median nerve, right? Median nerve, you learned in anatomy. This passes through this fibrotendinous junction here, and this is the carpal tunnel, and it crosses underneath this fibrous tunnel. This is the fibrous tunnel, and this is the median nerve, right? The median nerve. What is carpal tunnel syndrome? If the median nerve gets compressed under this fibrous tunnel, this causes tingling numbness of the hand because the nerve is being compressed. So the median nerve passes through the carpal tunnel to receive sensations from the thumb, the index and the middle fingers. So this is the supply of the median nerve, the thumb, the index finger, the middle finger and a part of the ring finger. This comes through here. This is the fibrous band, which is the site of compression of the median nerve, right? Carpal tunnel syndrome. This is the transverse carpal ligament, and underneath it is passing the median nerve. So carpal tunnel syndrome is pressure on the median nerve, the nerve in the wrist that supplies feeling and movement to the parts of the hand. So what is carpal tunnel syndrome? It is the compression of the median nerve in the wrist due to a fibrous band, tight fibrous band, lead to numbness, tingling, weakness or muscle damage in the hand and fingers. So numbness or tingling in the thumb and the next 2 or 3 fingers. These are symptoms. What will patient will come to you that I am having tingling numbness over my hand. So this is the symptoms of carpal tunnel syndrome is numbness. Pain on extending the elbow, very rare, right? Or pain on the wrist or hand. But mainly patient comes with this type of a symptom that I am having tingling numbness in my hand. They are also in chronic cases, in patients which have not been treated, it may cause problems with finger movements, wasting of the thumb. Basically, this is the thenar eminence. The thenar eminence gets flattened in these patients because of the wasting, right? And there may be a weak grip or difficulty in carrying bags. Carrying bags, this is a very common complaint. Patient will say, I am at the airport, but I cannot pick up my bag. That is a difficulty that patient faces. So what is the cause? The cause is mostly idiopathic, mainly because we don't know how it gets caused. Basically, what is happening is that the nerve is getting compressed under the transverse carpal ligament. But why it is occurring, we still don't know. The researches are going on, and it can happen in several ways. The swelling of the lining of the flexor tendons may cause it, like synovitis. Mostly patients right now come to us. Young patients are coming to us with carpal tunnel syndrome because people are working in the IT sector, and repetitive wrist movements like typing and working at the laptop for a long time can cause this, right? So osteoarthritis may also reduce it, and joint dislocations or fractures may also cause it, rarely, but patients come to us with tingling numbness of the hand. Patient is an IT sector professional, we know it's a carpal tunnel syndrome. After pregnancy, it is very common symptom. Patient will come that I have tingling numbness in my hand after pregnancy, after delivery, because there is fluid retention during pregnancy, which causes swelling of that part, and the median nerve gets compressed. Thyroid conditions like hypothyroid, so you always need to get a thyroid profile done of the patient. Rheumatoid arthritis, diabetes causes it. Women are more likely to get this. So diagnosis, history, patient will tell you the history that there is tingling numbness of the hand, or patient is having difficulty in picking up bags or having numbness. Physical examination, this is a very important thing, you need to know this Tinel sign. This is, you need to write, if the carpal tunnel syndrome short note is coming to you, you need to write Tinel sign, right? What is a Tinel sign? It is a way to detect irritated nerves. Tinel sign is not specific for carpal tunnel syndrome, it is for any type of nerve. If you need to examine, Tinel sign may be there. So lightly tapping the area, this area, you need to tap it gently, and this leads to the patient saying that my tingling numbness is getting increased. That is a positive Tinel sign. T-I-N-E-L, Tinel sign, right? So this is first test that you need to do. Next is Phalange's maneuver. Phalange's maneuver, you ask the patient to keep the hands like this for an extended period of time, around 30 seconds, and this causes the tingling numbness to increase. So this is a diagnostic test for carpal tunnel, Phalange's maneuver or Phalange's test. Tinel sign, Tinel is not a test, it's a sign. Tinel sign, positive Tinel sign is tingling numbness increases by tapping on that part, and Phalange's maneuver is you ask the patient to keep the hand like this, in like so in the picture for 30 seconds, and the tingling numbness gets increased. Okay? Also atrophy of the thenar muscles due to decreased median nerve supply and disuse, it causes atrophy of that part, flattening of the thenar eminence occurs. So now those were the clinical signs. First of all was history, the patient will come to you. Second of all, we came to two diagnostic tests, Tinel sign and Phalange's test, right? Third of all, we come to diagnosis. How do you diagnose this? You get an NCV done, nerve conduction velocity, we call it here. NCV EMG test, you get it done, nerve conduction studies, and it causes prolongation of the distal latencies. No need to know. Just write down nerve conduction studies or nerve conduction velocity, NCV. NCV test needs to be done. EMG, this is an electromyography, evaluates the electrical impulses from the muscle fibers. Just write these two names, NCV and EMG, should be done of that affected part. Treatment, first of all, first treatment will be non-surgical, obviously, because it is not an acute injury or anything, it's a chronic thing. So you first manage it conservatively. You go in for a CTS brace, CTS means carpal tunnel syndrome. The goal of treatment was CTS, reduce the swelling and pressure on the median nerve. So you use a wrist brace initially because it hampers the patient's activity. We ask the patient to wear it at nighttime brace, right? Night, so that the activity of the patient is not hampered. Keyboard and mouse supports may be used because if the patient is an IT sector professional, you need to change the workspace, otherwise this will recur again, right? So keyboard and mouse support is to be used. Vitamin B6 or pyridoxine, right? Pyridoxine we give it daily, once daily for 90 days, around 3 months. Takes time to reduce. You need to tell the patient that it will take time to reduce. You need to use a brace, you need to have some medicines, and then only it will reduce. And if it is not reducing, then we go in for a surgery. Also, there are median nerve gliding exercises, basically pulling your hand into a fist and then releasing. This is median nerve gliding. This causes gliding of the median nerve and it causes a little mobilization so that it reduces. Cold laser therapy, you don't need to know. Next step of management, first of all, you tried a conservative management for 3 months. Patient symptom has not reduced. What do you do? Next step of management is local cortisone injection. Corticosteroids and lidocaine injected locally into that area causes a reduction in the symptoms. And if oral steroids are usually not given, a local steroid may be preferred over oral steroids because side effects are more of oral steroids. So we don't usually prefer, we prefer a local injection on that part to relieve the pressure, inflammation on the median nerve. It will provide immediate relief to the patient. Patient will say, thank you, I am having less symptoms, but it may recur again. If it is recurring, and if the symptoms are not reducing even after conservative as well as local injection, then you need to do a surgery that is a carpal tunnel release. the transverse carpal ligament that is there, this transverse carpal ligament needs to be released. It is totally cut through. You don't need to again stitch it back. Just release it and keep it that way. Okay, endoscopic surgeries also come for this, but usually we do an open transverse carpal ligament release, open carpal tunnel release. And post-op you keep it in a splint. You can use the CTA splint as well. And rehabilitation, gentle massage of the scar tissue and modalities to decrease the pain. Progressive exercises, physiotherapy basically, which we need to start after the stitches have been cut. So around 2 to 3 weeks later we start. With the exercises improve fine motor control and dexterity. So physiotherapy needs to start. So what is carpal? So carpal tunnel syndrome, we've come to the end. So carpal tunnel syndrome is basically the compression of the median nerve in the wrist or the carpus by the transverse carpal ligament, right? Mostly occurs more in females than in males. Occurs after pregnancy, very common. Patient symptoms, patient will come with inability to hold bags, tingling numbness over the hand. So diagnostic test, NCV, EMG, nerve conduction velocity and electromyography, that gives you a diagnosis. And third of all is the treatment. First of all, you go in for a conservative treatment, splints as well as medicines. Second of all, local corticosteroid injection. If it is still not relieving, or if it's a chronic case, you go in for an open carpal tunnel release and you go in for a post-op splint and then you rehabilitation. So one more thing we'll discuss. So this is another common condition, another short note for you that occurs in the hand. It's known as trigger finger, right? Trigger finger. So what is a trigger finger? Achha, it is basically Stenosing Tenosynovitis, very long term. What happens is the ligament which is flexing the finger like this. This goes through a pulley here. This is the pulley, right? And this tendon gets swollen. That is tenosynovitis, means swelling of that or inflammation of that tendon, right? And this causes a thickening of the flexor tendon. And the main thing you need to remember here is A1 pulley, right? This you need to write down. The tendon is inflamed, stenosing tenosynovitis of the finger, flexor tendon, and the A1 pulley catches it, and that's why it causes a trigger finger. So what occurs is the patient will flex the finger and it will get stuck here and it will open with a pop like this, right? So that is a trigger finger. Patient will say it is progressively increasing. This is the inability to flex or extend the digit smoothly. Like this is a smooth movement, but that patient will have, in the flexed position, it gets stuck and then suddenly it releases with a pop. So patient will say that my finger is getting stuck. All the digits can be affected. Ring finger is most commonly involved. Most common finger to be involved in trigger finger is ring finger, followed by the thumb. It's known as trigger thumb. More than one digit may be involved. So this is the A1 pulley. Basically, this is the tendon, flexor tendon that is coming. Yeah, this is the hand. This is the flexor tendon. This is the A1 pulley. And if this tendon is inflamed, it gets caught here and it gets stuck. And then when she tries to extend it, suddenly it goes and it causes a triggering of that finger, trigger finger, right? So A1 pulley is what you need to remember. Do not need to remember A3, A5, nothing you need to remember. Only A1 pulley is the one that you need to remember. So what is trigger finger? It is tenosynovitis of the flexor tendon of fingers, and the triggering is caused when the tendon gets caught in the A1 pulley. So A1 pulley is at fault here. No need to know this. So again the A1 pulley here. This is the A1 pulley, right? So, so that is what is trigger finger we came to know. So what is the etiology? It may be congenital, it may be from birth as well. It may be associated with conditions like rheumatoid arthritis, diabetes, very common with diabetic patients. Diabetic patients come to us with this complaint mainly, with that I am having a trigger finger. Other causes may be abnormal collateral ligament that may catch on to a bony bone. No need to remember. Congenital and repetitive trauma as well as diabetes you need to remember, hypothyroidism, amyloidosis, rheumatoid arthritis and gout. Patients with these diseases have trigger finger more than other patients. So this basically the A1, the flexor tendon gets caught in the A1 pulley. Don't need to know so many names. Okay, signs and symptoms. We come to signs and symptoms. So what is there? Pain at the root of the finger. There is there because it is a tenosynovitis. It's an inflammation. So there will be pain. The patient may complain of pain, but the main complaint is triggering of the finger. Tenderness, palpable nodule. If you palpate that part, she will complain of first of all tenderness, and you will find a nodule here. And the locking of the digit, either correctable or fixed. Like this is fixed. If she cannot extend it beyond this, that means the deformity is fixed. If she can with the triggering, that is locking. Okay, now what is the management of trigger finger? First of all, you give medical management. NSAIDs. NSAIDs should be given as the initial form of treatment. Many patients improve with NSAIDs alone. Maybe combined with massage, ice therapy, splinting. And again, we come to corticosteroid injections. First of all, we come to medical management, splinting, as well as NSAIDs you give to the patient. It's not improving, go in again for a corticosteroid injection. The affected finger should be kept in an extended position. The splint helps to rest the joint, and locked digits will not respond to this type of treatment. That needs further treatment like a steroid injection or something. Corticosteroid injection, again like carpal tunnel, we need to inject it at the site of the lesion, that the A1 pulley, you need to inject it there. All cases of stenosynovitis have been treated with injections and have been reported to respond. It's very, the management of, if you give an injection, it causes instant relief to the patient, and you can immediately see the finger getting extended. And if symptoms have been present for longer than 4 months or persist after the initial injection, surgical release is important. So treatment, first of all, medical management with NSAIDs as well as splinting. Second treatment is local corticosteroid injections along with local anesthetic like lignocaine. Third is if it is not responding, or if it is a chronic case with a locked finger, you go in for a surgical release of that A1 pulley. You need to cut that A1 pulley, and then the flexion will be normal of that patient. And that's about it for hand surgery. Any questions? This is the surgical release. This is basically the marking, and that is the A1 pulley. It's a very small incision. You see the A1 pulley, and the A1 pulley is just released from here. Yeah, that's this is the injection site, and that's about it, right? This is basically a postgraduate presentation. Yeah, that's the A1 pulley. That's a pediatric patient. This is the A1 pulley. So, any questions?